What is really fun for me is to be surrounded by people a lot smarter than I am and who are very inquisitive. And training residents and fellows, it's hard for me, it's challenging, but it's very rewarding. And I think one of the neatest things to see them go on to their future career. Scott Shapiro was at WVU for residency and joined us. And it's amazing to think about 18 months ago, he joined us. He followed Gavi Kohlberg, and he will be going to Rutgers University starting this July to take a neurotology faculty position. And he'll be working with Ashley Wackham, who's a friend and colleague of mine, who's the chairman there. It is one of the neat things of neurotology as a group, while we really do try to push each other to do a better job with care of patients, whether it's research topics or clinical topics. And I think Dr. Preeter's lecture, and I think that should be readily available from last month. I think that's a great lecture for people who have acoustic neuromas as well as others who don't. And so while there are clinical topics, one of my goals was to work with Scott on something that I've had a big interest in, which is when you're training someone like Dr. Shapiro or Dr. Preeter, they go from residency where they're pretty good with doing mastectomies and good solid ear surgeries, whether it's for cochlear implantation, to now they're doing next level work, which is skull-based surgery, and whether that's Retrosigmoid Approach or Trans-Labyrinthine or middle fossa or other approaches. And so one of my hopes is, with the topic that Scott's going to present to you tonight, is that maybe we can get to a point in time when every surgeon and every patient is able to, ahead of time of surgery, take a CT scan and MRI scan and create a 3D view of the tumor. So literally you as a patient could see what the tumor looks like, because we as surgeons and physicians should show you what it looks like on an MRI scan. And Scott's going to show you what we've done so far. It's really in its infancy. We're hoping to publish some of our pilot data. So thank you, Scott, for taking time this evening. And thanks to the rest of you for being on here as well.
Thanks, Dr. Sami. Thanks, everyone. Thanks, Emily, and for everyone for lending us your ear, for a few minutes tonight. I'm going to share my screen, so hopefully you guys are able to see this in just a sec. Is that coming through okay? All right. Anyway, thanks a lot, Dr. Sami, and again to the Acoustic Neuroma Association, Melanie, and for all you guys for logging on tonight. I'm going to be talking about how we're using 3D printing in a few manners for care of patients for vestibular schwannoma. And you'll see it's been really gratifying, because it's been something that's been really useful for my learning and for us on the surgeon side of things, and for patients, for kind of explaining and educating them on what's going on, where their tumors are, what they look like, and what we might do if we're considering surgery for that. So I wanted to really kind of briefly just give a quick overview of what 3D printing is. And in the broadest sense, it's essentially using a computer-controlled device to build an object up, usually from also a kind of computer-generated image. And it's kind of distinct from a machining process like a lathe or a mill, which you may or may not be familiar with. Whereas these are usually taking a block of material and sort of whittling it down and reducing it down to a structure. And it's different from those. So those are kind of reductive manufacturing techniques. This is an additive manufacturing technique where you literally build it up. And what's sort of unique about that and special about that is it allows you to make generally more complex objects. You can make them hollow. You could, for example, whereas reductive manufacturing techniques are just a little bit more limited in what kind of things you can make. And this is really useful for us, because when what we're trying to model here is something really complicated, three-dimensional. Some areas are hollow, like the brain and skull base, and essentially what's inside of your head. And so we've used 3D printing and applied it to skull-based surgery. So really, how can we use 3D printing to improve vestibular schwannoma patient care? And we've really done it in three ways, as I'll elaborate on all of these in just a bit, but I'm just going to sort of list what we've been doing right now. And the first is that we've been able to show patients a 3D representation of their tumor. And that's been really neat because most of you have probably seen what these look like, whether it's been your tumor or online, or what the tumor looks like on a CT or MRI scan. And that can tell a lot of information for sure. But looking at a slice of one slice or a few slices of an MRI or CT scan is not the same as having an entire skull or entire half of a skull and a 3D representation of your tumor. And you can really get a sense of exactly where it is, where it's located and how big it is, or small. What's also been kind of unique is that they're really useful for explaining to patients the surgical techniques that we use, especially when we're deciding between surgical approaches. We can say, well, we take this angle of the approach, we make the incision here, we remove this bone and get to the tumor this way. And it just gives patients a better sense of which can be hard to do with words alone, of what we're actually doing in surgery, and empowering patients by explaining what's going on with their body. On the sort of our end of things, and for a training perspective, it's been really nice because it's these models are, as we'll show you in just a minute, you can manipulate them. You can remove bone. We line them with a certain type of tape which simulates the dura, which lines the brain. And so we can they're sort of interactive, and which is really great for a trainee like myself. These modeling techniques have been used for basic ear surgery, but have not been used for skull-based surgery, where we're accessing the deepest parts of the skull base and the brain. And from an educational perspective, it's really been great to really be able to use and interact with a 3D printed model of a half of a skull with a tumor, and then see that surgery happen or help with that surgery the next day. And you get a lot more from an educational perspective, and you're better prepared for surgery as well. And then the final way, also kind of on the surgeon side, is there's in certain situations, we're not, a lot of times it's very straightforward, but other times it may not be quite as straightforward what the best approach to use for a tumor is. And some of you have been involved with conversations with us or others about the different approaches used to remove tumors if a patient is having surgery. And a lot of it has to do with it's very individualized. It has to do with, what's the patient's hearing, where is the location of the tumor, where's the size, because different approaches have different pros and cons with those regards. And so if one of the questions is, are we going to have an adequate surgical corridor, essentially, are we going to have an adequate view and angle and access to remove an entire tumor, we can simulate that approach, and we might change our mind, or we might find that it's adequate or a good approach for surgery. So, and again, I think that's sort of these three things have all been really good. I think that one is really nice because it can not just educates us as surgeons, but it can make us better decision making, or it can lead to better decision making prior to surgery. So this is a representation of a model, and I'll show you a few of these in just a second. But how do we make the model? So we start with an MRI.
Hey, Scott, sorry to interrupt. My one question is, sure. I saw the slides you sent earlier. Is there anything graphic that we need to warn the audience about?
I was going to warn them. There's one picture and one video that does show actual surgery, and I'll warn you. And so I just, if I keep the order right, I should be able to let you know. It's not particularly gory, but if that's a problem for you, that's no problem. I'll try to give you a heads up.
Okay, thank you.
Maybe you can turn off. Thanks, Dr. Sami, for reminding me. And maybe that would be a good time to just maybe turn off the video and maybe just listen if that's okay. Yep. Nothing particularly graphic, but there will be surgery and that's a problem. So this is we're looking at an MRI scan of a patient with a fairly sizable vestibular schwannoma. I hope you can see my mouse. And as you can see, things are flipped when we look at imaging. So this is actually the patient's left side. And the MRI scan shows us the difference between the soft tissues really well. We can see the difference between blood vessels and brain fluid and brain tissue and tumor. Whereas the CT scan shown on the right here does a much better job of showing us the bony anatomy, whereas everything that's not bone or air is kind of just gray. And we can download these to the computer when patients have, when we're working patients up with tumors that are going to undergo surgery. And we can use computer software to essentially select out the tumor and some other structures of interest, like certain blood vessels, certain nerves that are of interest to us, that we're going to want to know about where exactly they are during surgery. And we combine these two, the bony information and the soft tissue information, to create a 3D model that looks something like this. You can see now that the tumor has been moved to its sort of proper location on the left side. And you can see these are some nerves and blood vessels that are important for us to know during surgery. And so this is what the 3D object or model sort of looks like. And this is what, after the sort of quote manufacturing or 3D printing process is done, the model might look like in the end. This is just one of the models we've used. Here's another one on the right side. This one here in the center has the entire skull base sort of printed or modeled. And you can see how this would be really useful to sort of show a patient, if you can flip this over, you can turn it upside down, you can look from every side, you can really see where the tumor is, how large it is, and especially if it's sort of an individualized representation of your tumor. This is a fairly sizable one. Some of them may be quite a bit smaller. Some of them may be more kind of buried inside this bone called the internal auditory canal that's sticking out into the brainstem here. Here's another one, a smaller tumor from a different angle, and we're showing just kind of half of the skull. And what you're seeing here is some of the blood vessels of interest that are highlighted as well. When we're and so you can imagine that this might be, again, it's been really gratifying because we take these to our clinic. We've done a handful. We don't do them for all the time, but even if we have tumors that look very similar to what a patient might have, it's really useful to kind of explain, this is what it looks like, this is the location, and this is the surgical approach that we might use. It's been pretty gratifying, maybe the most gratifying part, more so than kind of the surgeon's end of things, for decision making. I mentioned that we're using it on the educational side to simulate surgery. And each time we make a model, we really evaluate it really critically to sort of make sure it does its job as a simulation. And so there's we break it down further, but three kind of main areas that we evaluate when we print these models. And that's, are they anatomically accurate? So I might look at and then simulate the surgery maybe the day before, maybe a few days before the actual surgery the patient undergoes. And I'm watching or helping Dr. Sami and the skull-based surgery team during the case. And I'll make notes about, was everything, the model kind of had all the structures here? Was that the case in surgery? And because that's really important, obviously, if we're individualizing these models, is that borne out? Is it really accurate anatomically? Also, sort of tactile and visual properties. Does it look and feel like the real thing? Again, it's a simulation. It should look and feel like the real thing. And then just sort of an overall realism. How realistic is this as a simulation tool for education? And so these are just two. This is looking at a temporal bone, a 3D printed model before any work is done on it. The colors, we change the colors up for various reasons, but I wouldn't worry too much about that. But this one happens to be the skull is all white. This one, the skull is blue, and the tumor and some of the other relevant blood vessels are gray. And to give you a sense of sort of how realistic it is, I'll show you a few more examples that have been interacted with. I'm going to warn you that this one shows one still image of surgery. So if that's a problem, just maybe pop out. I'll give you a second to pop off or turn the video off. So this is that same temporal bone model. And to give you a sense that if you can look behind the top right of the screen, the ear, this is the left ear. This is kind of the orientation that we're looking. So we're looking behind the left ear, which has sort of been flipped forward out of view. So we're looking in the area behind the ear. We call it the mastoid. And so here we're looking at the mastoid of our model. This is the ear canal. And then this is what it looks like in surgery when the soft tissue has been removed and we're about to start removing some of the bone to get to the tumor. And you can be a judge for yourself, but I think it looks pretty similar. And as far as sort of being anatomically faithful, the size, location, and we'll show you in a second that even sort of the way you interact with and remove the bone even is similar. When we, after, this is what things look like before we've kind of done our exposure and removed bone to get to the tumor down deep in the skull base. But I'll show some examples after that has been done, where we've done a lot of the initial parts of the surgery and gotten deeper in towards the tumor. You may be familiar or may not be, and that's no problem, with a commonly used approach called the Trans-Labyrinthine Approach. And we don't need to make you anatomy experts here. But what I want to point out is that this is sort of a textbook diagram of what sort of the exposure should look like when you've exposed all the structures you need to detect, taking out the tumor in a vestibular in a trans-labyrinthine approach. And some things to point out are there's the facial nerve is this white structure here. The vestibular schwannoma itself is here in red. And there's the dural lining is up here, and the sigmoid sinus, a big blood vessel, is here. And again, the colors aren't the same. It's not, but as you can see, all those structures in our simulated surgery, and again, so I've drilled and removed the bone to essentially just like we would for a real surgery, and all those structures are still there. And so we have the middle and posterior fossa dura, the sigmoid sinus, this prominent blood vessel. It's a little bit hard to see, but there's a gray faint line of the facial nerve, and then down deep there, right where it should be, is the vestibular schwannoma. And I get this may just look like mush, but if the structures they're all there, and that's I kind of have a sense of that's sort of what they look like during real surgery as well. I'll show another trans-labyrinthine approach. This is the same exact orientation. So again, the ear's been flipped forward. We're working in the area behind the ear and behind and deep to the ear. And again, all the structures that are sort of textbook diagram of a trans-labyrinthine approach, they're all there. I think they're shown a little bit better this one. You can see the dura is a little bit white. That's that special tape we use. It's actually even soft like the dura. And there's our in gray here is our large big blood vessel called the sigmoid sinus, the facial nerve, and the down here deep in the skull base is the tumor itself, the vestibular schwannoma. And everyone's anatomy is a little bit different, so the angles are all going to be a little bit different, but all the structures are sort of there. And I think is a pretty faithful representation of what the anatomy and surgical corridor looks like in surgery. You may be familiar with another approach that we use commonly called the Retrosigmoid Approach. Again, the orientation is exactly the same here. We're working the left ear's flipped forward. We're working even further back behind the ear. This is what our sort of textbook diagram sort of says things should look like when you're doing a retrosigmoid approach. Here, the sigmoid sinus is kind of in front of us, and this is another blood vessel called region of a blood vessel called the jugular bulb. And deep down in this hole, after you made a craniotomy, kind of a square of bone is removed, you find the tumor deep in this area, in an area we call the cerebellopontine angle. And so we've simulated making the craniotomy, removing the square of bone, and you can see we're right up against the sigmoid sinus and jugular bulb like we're supposed to. And deep down in there is a vestibular schwannoma, right where we're supposed to. And so it really kind of does all the structures that are supposed to are there, and it really kind of faithfully represents that surgical approach and that anatomy. What I want to show here is that I mentioned, obviously you saw that I was able to interact with these models and essentially remove the bone and manipulate the dura just like you would in surgery. What I want to show here, this is actually a video of me doing that. So you can see that that we typically use a high-speed drill and a suction irrigator to very carefully remove the bone to get to the structures we need. And I'll kind of jump around here with the drill just to sort of show how you can drill and remove the bone over the different areas. And that white under there is actually dura, and you can even see me push on it because it's pretty soft as it's supposed to be. If you're not careful, you can actually put a hole, just like you can in a patient, you can put a hole in that dura and make a tear. And so we drill with a suction irrigator. Hopefully Dr. Sami doesn't criticize my technique too much.
I can't promise that.
Now we're looking deep down towards the tumor, and we'll excavate the bone on either side of the tumor. And again, there's more dura down there. That's what that white is. And so you can really interact with this model in such a way that really does a pretty good job of simulating surgery. And each time we make one of these, we sort of evaluate it on those points. And the next slide is going to have a video of actual surgery. It's not the exact same step in surgery, but you'll see that a lot of the same structures are there, and you'll see sort of how the drilling and bone removal is done. And I hope you'll agree, but I think it's pretty similar. So just again, another heads up, the next video is actually an actual clip of surgery. So maybe take a second to turn off your video if that's not for you. And so this is the sigmoid sinus, that big prominent blood vessel. And we haven't done some of the deeper bone excavation that we've shown in the last one, but we're just starting that process. We're actually identifying and skeletonizing the facial nerve, which was already done in the previous one. But I hope you'll agree that, obviously there's blood in this one. Our models don't bleed. So that's something that perhaps in a future one we could incorporate somehow. I haven't figured that out quite yet. And I hope you'll agree. I think that just based on a visual representation, that's pretty similar. I can tell you that it feels pretty similar too, which I think is important, because a lot of this, how fast your drill is going, how much pressure to use, those are important things to do during surgery. And then the last way that, and I think this is certainly in its infancy, and I would say almost a possible application for these 3D models is in certain cases. I think these are the minority of cases, but it certainly happens where we're sort of going between two approaches, where it might be applicable to use both approaches, but we're not certain one is not clearly better than the other. And typically for this situation, we're talking about retrosigmoid versus the Trans-Labyrinthine approach. And without giving too intense of an anatomy lesson, the retrosigmoid approach, you're a little bit more posterior, sort of kind of behind the ear. And it's good for getting tumors that are more dug into this pink-purple area deeper in the brainstem, and not so good at getting areas that are out closer to the ear and inner ear structures that are in green. The Trans-Labyrinthine approach is a little bit better at a lot better at the lateral tumors that are closer out by the ears, by the inner ear structures. It also gives you a very good view of here, but the downside of it is that it guarantees hearing loss. So in certain situations, for example, a patient that has good hearing but has a tumor that is starting to extend into this green area, we are sort of weighing the risk of, well, do we want to do a retrosigmoid approach, but possibly not have as good access to the most lateral extent of the tumor and run the risk of maybe leaving some behind? Or do we want to be a little bit more sure that we're going to get it all, but guarantee them hearing loss? And so what's been unique, so for example, this tumor here is extending into the internal auditory canal out laterally by the ear, but it doesn't go very far down there, but it may be challenging to get the angle for a retrosigmoid approach may not be able to get all of it, because again, the angle is more from behind and it's hard to see out towards the inner ear structures very laterally. And so what's been interesting, I've done this in a few of the models, but one in particular where we were unsure if we were going to get it all, is I simulated it the night before. So this would be our angle for the retrosigmoid approach. And again, the trouble is getting this part of the tumor out. And I simulated it the night before. This would be the angle for the Trans-Labyrinthine approach, a little bit more direct, but again, guaranteeing hearing loss. So I simulated it. We made a craniotomy, meaning removed kind of a square of bone or oval bone and accessed the tumor. And what I found was that we're actually able to see and have an appropriate angle and surgical corridor to clear the tumor at its lateral extent, meaning that the approach was going to be adequate to get the tumor out. And I've had one that was not the case. And usually we can anticipate this beforehand, but occasionally it's very close. And occasionally our scan is can not necessarily mislead, but can over or underestimate the extent of the tumor. And so having a 3D printed model and able to simulate this surgically has been really useful. Sure enough, the next day we did surgery on this patient and we were able to get all the tumor out with the retrosigmoid approach. So that's how we've used it currently. I think it has some other future applications. I mentioned that a lot of times the first step in surgery is making a craniotomy and just sort of determining what's our window into the skull. Again, we remove a bone and then we put it back at the end. But the angle and size and location of all that are all really important, because if it's not done perfectly, you won't be able to see and do all that you need to do safe and complete surgery. And so I think by simulating things, you might be able to optimize the location of the window into the skull and optimize the craniotomy. The other thing is that I mentioned that we are highlighting with the computer software certain other structures besides just the tumor. important blood vessels like the sigmoid sinus, the basilar artery. But what we're starting to get better at is identifying the nerves that go through the tumor, like the facial nerve. And so it would be really useful if we can identify, in fact, we've done it here, we sort of lose the facial nerve as it goes into the tumor. But if we can identify where the facial nerve is located relative to the tumor before we even do surgery. Sort of similar to that is that if we can identify the blood supply of the facial nerve and the cochlear nerve, the hearing nerve, we can, and we know where those are, we can do surgery and safely protect those structures, because sometimes it's not just the nerve itself that we're concerned about, but we don't want to compromise the blood supply to the nerve, which can sort of have the same effect of causing damage, even if we protect the nerve itself. And finally, I think this has a lot of applicability. Obviously, I'm speaking to all of you at the Acoustic Neuroma Association, but I think I'd be remiss if we didn't mention that we do other skull-based surgery approaches for other things like CSF leaks or similar or non-acoustic neuropathology. And I think jugular paragangliomas, meningiomas, and I think it has a lot of applicability for similar approaches that are used for those surgeries as well. So I think it's just certainly in its infancy, and we hope to further develop it. I think it's really neat because it's kind of it sort of tickles our fancy on the education side on making us better surgeons with the surgical approach, and it's been really gratifying to really just show patients a 3D representation of their tumors and what's going on, what's going to happen if we're considering surgery. Obviously, this is not done in a vacuum. This is just part of our team. Sami, Dr. Zuccarello, Ali Maines, Frank Rubicki from the 3D printing lab, and Prashant Ravi as well, Dr. Breen, and again, there's a whole group here. This is just the tip of the iceberg, but so thanks to them and my mentors, and thank you guys for your time. I'm happy to take questions. I know you guys are all anatomy experts now too, so.
Thank you, Scott. Great talk. Mr. Fisher had a question, Scott. You may or may not be able to address it. He asked about robotics in relation to this for the future.
I think that's really interesting. I think that certainly having, and let me preface this with, I have no, knowledge or sort of special interest in robotics, so I'm just sort of speculating. But I know that to do it, you have to have a accurate 3D model, program, essentially like, just like where I'm physically simulating the surgery, you have to have an accurate 3D model and essentially have, the robot or simulation simulate that surgery to make sure and essentially do checks like, are you getting through into a critical structure? And really asking your representation of, are the same question that I'm asking, what's our surgical access? How do you get access to all the tumor and not damage critical structures? And so I think the questions are sort of going to be the same. I think it's going to be a computer model or a computer's program that answers them. So I certainly think that the same sort of processes, not necessarily actually printing it, but generating the computer image and then simulating it with a computer program. You may actually be able to his point, you may actually be able to print the model and have the robot practice on it to do like a double check, not just saying, well, the simulation said it was okay. We actually practice it with another model, which should kind of be another check. I think that'd be interesting. I know that there have been a few groups that have done robotic cochlear implant surgery. Again, not nearly as complicated as this, but the same sort of idea of getting to a certain area while avoiding critical structures. So.
Mrs. Beatty asked, do you know of other groups across the country that are doing 3D printed models? Because when you and I started this research project, I did not see a lot of work yet in this area. They've been in other areas, but do you know much with your literature search on what's been seen?
I think there are a lot of groups that are doing 3D printing for ear surgery and mastoid surgery. And I would say just in general, 3D printing is sort of a very popular, sexy topic these days. It's sort of new and getting better and cheaper for that matter as well. There is a lot being done with 3D printed models for practicing ear surgery. They're kind of the very first steps of some of the surgeries we do are sort of very similar to ear surgeries. And you guys may or may not be aware, we do when we learn, we practice a lot with cadavers. And sometimes they're in short supply. And sometimes as an adjunct to that, practicing with a 3D printed model like this can be really useful for mainly residents that are learning to do some of the more basic ear surgeries. I think we're definitely unique, at least to my knowledge, at least no one's published just yet, on using it specifically for skull-based surgery, for using it for acoustic neuroma. And I think most are using it in the setting of, well, they did it for one and they practice on the same one. I think really what's special is I'm more interested, and I like to, I certainly still have a good deal to learn, but I'm more interested in sorting what are the nuances specific to this patient's tumor that are going to make us better surgeons tomorrow when we actually do the surgery, and not just, oh, well, let me practice on any acoustic. It's say this one is close to this structure, but it's far from this structure, so we're going to have a better sense of getting it out this way, and I need to be careful here. I can be, I want it, and I can be more aggressive here. And those kind of questions, I think, are at least that's sort of our interest. But I definitely think that 3D printing is out there and getting more widespread, but not for this.
Dr. Preeter, you have done, obviously, as we all have, a lot of temporal bone lab work. If you want to talk about a little bit like that, like Scott's talked about, but then also you like doing a lot of endoscopic techniques, and you have a different model. It's not necessarily a printed model, but it's a good way for you to train your residents up in Dayton, right? If you want to talk a little bit about that, that also gives the audience a little bit of understanding on why all the simulation work is so helpful.
Yeah, it is really helpful, especially to the extent of the resident training. So the residents actually only get 2 temporal bones per year. And so, if you're in the lab a lot of time, you can really get through 2 temporal bones relatively quickly. Now, we have a schedule, and so, we, as long as the residents follow the schedule, they go through 1 temporal bone every 6 months. But if a resident has a special interest in otology surgery, they could easily go through that temporal bone in a day or even a weekend if they had a pretty intensive plan. But anyway, if we have the opportunity to use models for training purposes, I think that could be much more efficient and give the residents even more practice. So we currently have a limited supply, and so having the production of these 3D models would be a fantastic training program. We, as Dr. Sami alluded to, we currently have a little practice model using endoscopes, and we unfortunately don't have the opportunity to practice on real models. We have this little device with little hoops and rings and sticks and things that are on a miniature level, and the residents are able to basically play little games with using the endoscopes. And so certainly a real or a replicative 3D model would be a fantastic option for the residents. And so I'm really excited to hear Scott's lecture. That's fantastic, and certainly look forward to what we have to learn from all these models.
Thanks, Dr.
And I would think that the challenges for us, Scott, are twofold. One is, right now we've done 6 or 8 of these.
Yep.
And the cost, as with a lot of things, new technology, it's a little bit cost prohibitive for us. And so we are looking forward at some point in time, let's say Dr. Preeter, Dr. Shapiro, when he's out in practice, for me, with my future fellows, et cetera, I want to get a 3D bone printed for every single patient. Right now, insurance does not cover that cost. And so that cost is borne by the patient. But that's one of my hopes at some point in time, that it can be what's called bundled with the surgery, that it's part of the surgical process. Our patients don't see it on their end, but it's beneficial for the residents and fellows to be trained.
There are 2 questions. There are 2 questions that
please go ahead.
I can maybe answer sort of together from David Kellogg and Nancy Riley about the approach selection. I think it is the goal. I don't think we have not at all proven that this is the case, but I think we're trying to use, one of the areas that I and the group are trying to use the simulation is to, I wouldn't say it necessarily increases our ability to save the hearing. I think it just allows us to choose correctly, if that makes sense, or be certain about our choice.
Right.
And so because the example I used was using a Retrosigmoid approach, which has the possibility of hearing preservation. it may be the opposite. And I mentioned there was a case that was that case where I didn't think that we were going to be able, or we thought that there was a good chance that using that approach would not be able to clear the tumor that side. And sure enough, in the simulation, we were not able to. And we had been speculating that we're probably going to go to a trans-lab approach, and we did anyway. And so I don't think it necessarily equals hearing preservation, but I think it makes it so that we have a much decreased chance of leaving tumor behind. And again, it may, for some shortened tumors, it may be that, but I would not say with broad strokes that it sort of means that we can preserve hearing more. In the end, that would be the goal, would be sort of to make sure that we have complete resections and better hearing results, but we're not there yet. I think that's the goal though.
So some other questions there, Scott. So one of the patients, Mr. Kellogg, asked about the 2.4 centimeter tumor, which is still a sizable tumor, and Trans-Labyrinthine Approach 17 years ago. And he writes, even now I've read that radiosurgery long-term doesn't save hearing. This has helped surgeons preserve hearing by doing something different. So I think Scott said this well. So when Dr. Preeter, Dr. Shapiro, and anyone sees patients with acoustic neuromas, you look at everything from the history, their symptoms, to their MRI scan, to their hearing, to their health status. I think this is just one more tool. I don't think it's the end all be all. As Scott said earlier, like what we're struggling with right now is, I would love for us to know ahead of time. So for example, out of the last 6 weeks, I went on 2 patients that we thought had acoustic neuromas. They both ended up with facial nerve neuromas. And so I'm relying on some testing such as electroneuronography. I'm looking at the VSG test, hearing tests, but I don't know for sure until I go in there for some patients where the tumor's coming from. My hope is that with some of the stuff that Scott's doing, that we can start doing more modeling work. So ahead of time, we know, hey, this is coming from the facial nerve. And maybe we need to do a different approach. We're not going to go through the labyrinth and destroy the hearing. Maybe for this case, we do a combined middle fossa and retrosigmoid approach. And that's our hope to improve patient care and outcomes as time goes on. Someone else asked about robotics. I'm sorry, go ahead.
Sorry, go ahead.
Someone else asked about robotics. I can talk a little about robotics. I had an interest early in my career on looking at robotics. The Da Vinci, many of you may have already heard of. The Da Vinci is used for urologic procedures, gynecologic procedures. It is not meant for bony work. It is meant for soft tissue work. So a lot of the approaches that we do in conjunction with our neurosurgical colleagues involves, as Scott showed you, a high-speed drill. And that drill is not so easy for the robotic arm to deal with and manipulate. Doesn't mean it can't be done at some point in time. There are groups around the world, as Scott said, that have used a robotic drill for cochlear implantation. But that is a very finite process. It's much less complex to put an electrode in the cochlea to help someone hear than it is to do a tumor resection and do a surgical approach like this. So I do think at some point in time it's feasible. What's going to also happen is the cost of all this stuff, because someone did ask, hey, what's the cost? And it is, these models aren't that expensive. We said anywhere from $300 to $500 right now. But using a robotic system, I cannot fathom how many millions of dollars of robotic systems. So for example, Da Vinci itself costs 1.7 to 1.8 million. And there's a contract that the Da Vinci robotic system has to have with the hospital. They're disposable, and it's really cost prohibitive, and insurance does not increase your reimbursement if you use a robot. So someone's got to pay for that somehow. Jimmy, you guys probably have, remind me, are you primarily out of Kettering? Jimmy, which is the main hospital you like to operate out of?
Yeah, Kettering.
So I'm assuming they have a couple of Da Vinci robots there, but same thing for urologic, gynecologic, general surgery procedures.
Right.
Yeah, I think, Dr. Sami, one obstacle we've encountered is it takes generally, not necessarily a radiologist, but somebody with generally like an MD training to review the model and segment it. And so, if we do one or two, either we do it or we ask a colleague who's interested in the research. But if we're doing it on all patients, at some point, I think sometimes just general sort of reimbursement for whether it's their time or the radiology services is sort of one thing that we've encountered.
Right.
Again, we don't mind doing it because our patients and we have an interest in this, but if not necessarily the case, depending on where you're at. So.
Now, some of you may also have seen, so you look at simulation. So here we are, we're basically the bigger grouping of all this is simulation. So if you think about simulation, that includes things like, Formula One drivers who will simulate the car circuit before they take their car out for different racetracks, race circuits. Look at pilots who may fly a Boeing 777, and if they haven't flown in a while, they have to do a certain number of hours for the FAA. Greg Wyatt, who is at Nationwide Children's and a dear friend and colleague of mine, and I don't know, Jimmy, if you ever met Greg across your paths, but Greg has done some simulation work with grant funding from the NIH. And so I did some work with him 12, 13 years ago where we looked at a simulator using graphic cards. It's almost like doing a video game and trying to figure out with the video game, can I upload the CT scan and MRI images to the computer? And then I can play around with it on a computer as opposed to a 3D printed model. So that way you can do it multiple times. The downside of 3D printed models, once Scott uses up a 3D printed model, it's done. You can't keep on reusing it. The nice side about a nice option about computer simulation is you can do it over and over again.
They're all on my shelf here.
Other questions from the group? Thank you, Scott, for your time.
Thank you, everyone.
Emily, are there new patients that want to introduce themselves to the group, or anyone wants to give a little bit of time for sharing? And for next month, by the way, I'm going to have Stephanie Lockhart, who's the head of audiology. And when Emily and I talk about different topics, I want to make sure this is educational every month for everyone. We'll do the first Monday of each month, 7 p.m. And Stephanie Lockhart is just going to talk about hearing aids. There's a lot of different things we could look at, from hearing rehabilitation and restoration, from bone conduction devices to cochlear implantation for single-sided deafness, et cetera. But I thought if I just broke it down into a simple topic, just one topic next month, hearing aids, and then we can also talk about bone conduction devices, another section. That way we always refresh the topic so that it's beneficial for all of you.
And we're obviously open to the suggestions that you guys
absolutely
have every month. Scott, I just picture you having these cabinets. I don't know if when you were a kid, I'm probably significantly older than you, but when you were a kid, if you went to the orthodontist and they had all the creepy teeth sitting everywhere, the molds of your mouth, and then every time you did something dental, they were like, oh, let me go dust off the one we took 3 years ago and make adjustments. So I don't know, maybe you guys will start collecting all of our brain tumors, and then I don't know, in the future, if any of us have issues in the future, you can go and add to it. I have no idea. I don't know, but it'll be Scott with the collection behind him. You're on mute, Scott. You gotta unmute yourself.
I'll show you the collection. You could say if it's just creepy or if it's scientific. I don't know. Yeah.
No, I mean it's pretty great. But recently, I've taken my kids to the orthodontist, and they do the 3D models from the X-rays. They do it. It's all electronic. So now the orthodontist doesn't have creepy shelves anymore. So I don't know.
But my guess, Emily, since orthodontics work, there's quite a bit out-of-pocket expense. How do they pay for that? Is it part of the fee for the orthodontics?
Well, it's about $6,000 per.
There you go. Yeah.
So since we've
right,
done
I mean, so that's the big challenge right there.
Yeah. It's awesome.
Emily and Dr. Sami, I have another suggestion.